Welcome to an MS Views and News educational program. This program is called Compass to MS Care. Okay, and we've been doing this program in rural and underserved communities around the United States for the last 5+ years. We will always continue to do this because there is always rural and underserved communities. So we're providing, valuable information which patients need concerning resources and why they should be doing certain things that maybe their general neurologists from those areas have no clue what really to recommend for their MS patients. So I want to let you all know first, we are supported by a lot of different pharmaceutical. Why? Because they know about our programs, they know about what we're doing and what we're able to provide for everybody. And so for today's program, we have support from EMD Serono, Genentech, Biogen, Novartis, Bristol-Myers, Squibb, Sanofi, and Banner Life Sciences. And I tell you all this because they should be recognized for, what they do to support our programs. Exhibiting today, we have Bristol-Myers Squibb, Banner Life Sciences, Genentech, and Janssen. So, we're glad that they were here and able to give you all that are in attendance, the information that they're able to give you about the medications they have. All right, so anyway, we have Dr. Boster, and I just want to say, he's not personally my doctor, but I want to thank him for all that he does for the MS community. He speaks for us probably pretty much to more so than any other MS neurologist, and I just want to thank him for being available. So come on up, Dr. Boster. Jump. I want to see you jump.
Now, when Stuart and I do these lectures, we get a list of topics that sponsors are interested in. All right, so they put this list together, and then Stuart gives it to me and says, here, can you talk about these topics? So listen to the topics that I was asked to speak about today. MS disease progression, understanding new MS treatments, nutrition, health and wellness, MS symptom management, access to MS care in your region, and finding resources. And I have 60 minutes. So I figured out a way to do it. I have a lecture that I put together while I was driving here in my head. No, I was driving in a car. I was thinking in my head. And I'm going to call the lecture Drugs, Sex, and Salmon Rolls. And you'll see at the end of the lecture whether or not the lecture Drugs, Sex, and Salmon Rolls hits all of those points or not. Fair? All right, so let's get rocking and rolling. If we're going to talk about multiple sclerosis, let's level set the stage and kind of talk about what is multiple sclerosis. All right, so what exactly is that condition? In order to understand MS, we have to think about the immune system. All right? Many of us in this room have become very sensitized to the immune system over the past 2 or 3 years because it's in the press a lot with regards to infections and vaccines and stuff like that. The immune system is the part of your body that fights off bad guys. So when your kid comes home from preschool and sneezes all over your face and then you get a cold, you don't succumb to that cold because your immune system identifies the cold as a foreign invader and murders it and clears it from your body, and then you finally feel good after a couple days. That's the immune system's job. The immune system is not supposed to attack you. It's supposed to leave you alone. So if I use a military analogy, no friendly fire. You don't want to shoot your buddy on guard duty. That's super uncool. Autoimmunity is a situation where the immune system made an error in judgment, where it by accident identified part of your body as a foreign invader. And when it sees that part of your body, it thinks it's looking at a bad guy, and so it attacks it. The problem is it is you. And once that autoimmunity is set up, the human body doesn't know how to undo it. And so for the rest of the life of that human being, when that human being's immune system does its tour of duty and sees that part of you, it thinks it's looking at a bad guy and it jumps on it. Now there's a lot of autoimmune conditions out there. So diabetes is a very, very common condition that affects people, and childhood diabetes is an autoimmune condition where the pancreas gets attacked and gets damaged and can't make insulin. Rheumatoid arthritis is another very common autoimmune condition where the immune system attacks the joints. And you'll have joint deformities and pain and a bunch of other not nice stuff. Multiple sclerosis is an autoimmune condition where the immune system attacks the holiest of holies, the supercomputer that runs the body, the brain. And it attacks the superhighway. That's the spinal cord that takes all the information from the brain down to your feet and back up. And MS impacts us in 2 ways, pathologically, like bad things that happen to you. You can accrue neurological disability. So you can collect neurological problems from MS in one of two ways. Way number one is what we call RAW, relapse-associated worsening. I'm going to talk to you about that in a little bit. Way number two is what we call PIRA, progression independent from relapse activity, right? But I'm getting ahead of myself. Before I jump into a discussion about RAW and PIRA, let's back up 1 second and say, what are we going to talk about with this drugs, sex, and salmon rolls? Because I decided, poor Thomas, it's like, Aaron, really? Seriously? Yes, Thomas, seriously. I decided a long time ago that I was going to learn how to do MS better than the men that took care of my family in this town. And I told my parents when I was really little that I would do that. And I had a very directed course. So I was the weirdo in high school that said I want to be a multiple sclerosis doctor. And then when I picked an undergraduate that had a neuroscience program because I wanted to be an MS doctor. And I'm the weirdo that has been very, very directed. And I have almost like a mission to energize and to empower and to educate people and families impacted by MS. So it's with that vein that we're going to have this discussion about, Thomas, brace yourself, drugs, sex, and salmon rolls, with a goal of living your very best life despite having multiple sclerosis. Fair? All right, so the first topic, drugs. And when I talk about drugs, I'm actually talking about MS drugs. So it's not that exciting of a discussion. We can have a discussion about other drugs some other day. And so now we come back to this idea of how people with MS develop disability. RAW, relapse-associated worsening, goes like this. I suffer an MS attack, which makes my left leg weak, and it doesn't get all the way better. So after I recover from my MS attack, I have a little hitch in my giddy-up. So now I don't walk as well as I used to. I still walk, but my leg's not what it used to be. So I have accrued a degree of neurological disability because of that. That's not the only way that people with MS get worse. In fact, that's the less common way that people with MS get worse. What's more common is this other nasty thing called PIRA, progression independent from relapse activity, where the human being just gets worse without an attack. And some of you in the audience are assuming I'm talking about so-called secondary progressive MS and the second half of the disease. I'm not. I'm talking about as soon as you're diagnosed, if we look carefully, there are two things driving MS disease pathology. And we want to use lotions and potions and medicines to quell that, to make it better. So the drugs that I'm talking about are disease-modifying therapies. If you want to live your best life despite having MS, there's a bunch of things that we need to be doing. We're talking about 3 today: drugs, sex, and salmon rolls. But as it relates to drugs, we want to make sure that we are using a drug and we want to make sure that it's working. And the phrase that I've crafted is I want you on the most effective disease-modifying therapy that you're comfortable taking. And I really, really crafted that sentence very carefully. I want you on the most effective drug that you're okay taking. Because it's not my body, it's your body, it's your brain, it's your insurance money, and you have to be cool in the gang with whatever it is that we're doing. It's very big of me to say, oh, this is going to be great, you'll do super, right? But I'm not the one that's actually having my veins spiked or jabbing myself or swallowing a pill. And so I want to talk to you a little bit about the goals of disease-modifying therapies, and then we'll talk a little bit about how some of them work. And then at the end, I want to tell you about a brand new therapy that we're developing that I'm very, very excited about. I can see you nodding your head. Yeah. All right, so the goals of disease-modifying therapy are not to give you back stuff you lost. I wish that was the goal of disease-modifying therapy, but it ain't. So if you have 3 children and you start birth control, you have 3 children. They don't go away. And my joke is, if you want to know why you're on birth control, go hang out with your 3 kids. Because you don't want an unplanned 4th child, right? That's why you take birth control. You take a disease-modifying therapy to prevent future brain damage, to prevent future attacks, to prevent accelerated shrinking of the noggin, to prevent the accumulation of neurological disability. It's unlikely to give you back stuff that you've already lost. And if that doesn't sit well with you, good. Because I want you to use that as the reminder of why you're putting up with me and that drug, because you've already gotten weak on one leg and we don't want it to happen on the other. Does that make sense? Now, when we talk about what's the goal of MS care, it's complicated. There's some other diseases where it's pretty straightforward. High blood pressure, make it lower. Right? Diabetes, control the sugars. high cholesterol, make that number better. In MS, we're trying to achieve NETA, no evidence of disease activity. Show of hands in the room who've heard of that before, NETA. Some of you have heard of it before. So NETA, no evidence of disease activity, is the target that we're shooting for. That's the goal that we're trying to hit. That goal is no attacks. That's the goal, is to not have attacks. That goal is no new spots on your MRI when I get one. That goal is no accumulation of neurological disability on your exam. That goal is not achievable. Well, Aaron, what are you doing? If that's your goal and you can't achieve it, why are you on stage talking? It's a goal, it's a target. Think with me about basketball. All right, so March Madness, I'm told. A bunch of coaches get together with a bunch of young men, and I imagine that all the coaches say the exact same thing. They all tell their team, we're gonna win national championships. But really that means that like 63 coaches are liars because only one team wins the championship. So what are those coaches saying? Well, no, they're not lying. What they're actually saying is they're saying, gentlemen, we will conduct ourselves as champions. We will practice and eat and sleep and pray and study like champions, and then we'll see what happens. And if that team went out and lost the first game of the season, they don't kill the coach and disband the team and turn the university off. They assess what happened, they make a change, and they re-up. That's the way I think about NETA, no evidence of disease activity. That's like saying we're going to shoot for national championships. One of the reasons I like NETA is just like in basketball, you know whether you won or not. All right? So if you have an attack and you're taking a medicine that's supposed to stop that, that didn't work very well. And you don't need to go to doctor school to figure that out. If I get an MRI and you have a big new white circle that's glowing on your scan that I didn't see last year, that's not okay. Because we had a birth control pill to prevent that. And if you're accruing neurological disability on your exam despite taking a medicine, something ain't right. And so I like NETA because you don't have to be highfalutin or go to a special fancy pants place to figure that out. And if we see those things aren't okay, it gives us an opportunity to intervene, just like that basketball team, and make a change and then re-up. Make sense? Now, there are, I'm very, very proud to share, 27 different formulations of MS medicines. Why am I proud to share that? Because when my uncle was diagnosed with MS, they had 0 medicines. And when the very first medicine became FDA approved in 1993, he was fixed in a wheelchair and couldn't really move his arms very well. And it was really too late for him to respond to that beta serum. We didn't know that at the time. He took it, had flu-like symptoms. You fast forward just a handful of years, and we have so many different medicines at our disposal. It's very, very exciting. Now, if I went through every single medicine, you'd get bored and they'd turn the lights off and stuff, and then you'd want to go home and go to bed. But I do want to give you sort of an overarching idea of what the medicines do. And so for that, I'm going to use some props, which is going to make Bill upset. All right, Bill, let's see. I need your bag. What's he doing? Just wait, I'll show you. All right, so this is the blood-brain barrier. Fair? So this in the middle is the blood-brain barrier. Over here is the bloodstream. Then there's the blood-brain barrier, and over here is the brain. Not too complicated. So the way that MS works at the cellular level is you have these naughty cells. They live in the bone marrow and the bloodstream. Those are the B cells and the T cells and all that stuff. And some of them are sassy. They made a mistake and they think that your brain is a foreign invader. And they cross the blood-brain barrier into the central compartment where they see your brain and they think they're looking at a bad guy and they beat it up. Every single one of those MS drugs that I mentioned, the 27 drugs, do something to jack that up. All right? So for example, some of you have heard of interferon beta products. There's a bunch of different interferon beta products. Those are injections that you give yourself. And what they do is they tighten the blood-brain barrier. So if you think of the blood-brain barrier as like the straw house and the 3 little pigs, they turn it into the stick house. It's a better house. And so it's harder for those cells to get through. Make sense? You heard of a drug called Tysabri. That's an infused medicine in the vein. It's a high-efficacy medicine. It turns the straw house into the brick house. You literally can't get any cells through. It's a very, very effective therapy. You've heard of a drug called glutathione acetate, right? Which is an injection that you give yourself 3 times a week, Copaxone. That works by teaching the immune system not to be excited about those targets. You just show the immune system myelin, fake myelin, and the immune system's like, all right. And then you show it to them again and again and again. And when the immune system goes over here and sees myelin, it says, I saw that yesterday. And it's less likely to attack. Have you guys heard of these drugs, these S1P1 receptors? These are pills, like Gilenya and Mayzent, Ponvoy, Sposia. These pills are really, really cool. What they do over here in the bloodstream is they trap about 80% of your cells in your lymph nodes. So you take them out of the bloodstream and lock them in the lymph node. So if they can't get in the bloodstream, then they can't cross the blood-brain barrier and attack the brain. That's how those drugs work. You've heard of a drug called Tecfidera, and now there's a bunch of different versions of dimethyl fumarate. There's 3 that are FDA approved, which is pretty awesome. Those drugs work by making the body think that you're under oxidative stress, so the cells over here respond with an antioxidant behavior, which makes them lovely and they're less likely to attack over here. So that's pretty interesting. There are some really cool newer drugs out there. You're very familiar with the B-cell depleters. These are things like ocrelizumab, rituximab, ufatumumab, Kesimpta, Rituxan, Ocrevus. These drugs identify B cells and murder them. Because if the B cell is depleted, it can't stimulate the T cell to attack you. Let me give you an example. I went to high school very close to here at Gahanna Lincoln High School. 717 kids in my graduating class, massively overcrowded, 4 lunch periods. And very frequently, the hallways were super crowded, and you got a giant backpack on, and you're trying to get through the hallway, and you bump into a guy. Well, there's only one way to take care of that. You got to meet behind B building at 3:30 and put your dukes up, and you got to fight for your honor, right? And so I attended some of these functions socially, and it was very interesting. What I noticed is when 2 pugilists show up to figure out who's tougher, they show up with 6 of their very closest friends behind them. No kid shows up to fight by himself. All right, he's got his buddies. What do his buddies do? They egg him on. Go ahead, man. Whoop his butt. I'll hold your book bag. Go ahead. All right. So in this analogy, the guy fighting is the T cell. His friends are the B cells. With these B cell depleters, we just murder his friends. So he shows up to fight. Oh, you know what? Never mind. And then he leaves. And that's actually the way that drug works, which is really, really neat. There are 2 other drugs that I'm very fond of. One of them is called alemtuzumab or Lemtrada. And there's another drug called Mavenclad. And they're very different, but they both mechanistically do something kind of cool. They reboot the immune response. So they don't block the barrier. They don't murder the cells over here. They knock them down and rebuild them to behave differently. And there's all these different mechanisms of action. And I think about the show Star Trek very fondly. You guys remember Star Trek with the most famous doctor ever, Bones McCoy? And he had that darn tricorder. I want one so bad. He flips it open and goes, they've got MS, Jim, damn it. You know, we need a hypo spray. You know, and it tells them the diagnosis and the treatment, and it's really, really great. We don't have that for MS yet. I look forward to a future where I can check some blood and I can look at your immunology and your genetics and I can say, ha-ha, we're going to use drug A or drug B. Right now, we don't know how to do that. And having options is awesome. And before I leave the first of 3 topics, drugs, sex, and salmon rolls, I want to talk about a drug that we're developing that I'm very, very excited about. Show of hands if you've ever heard of Bruton tyrosine kinase inhibitors, or BTK inhibitors. Now, when I mentioned to my wife that I was studying BTK inhibitors, she said, oh, I know about that. Bind, torture, kill. And I said, excuse me? And she goes, yeah, the serial killer. And I had no idea what she was talking about. So I watched a documentary that night about a very, very disturbing human being who was a mass murderer, and his monocle was bind, torture, kill, which is not what we're talking about, okay? No. We're talking about something inside a B cell. Bruton tyrosine kinase is like a machine in a factory, all right? And when that factory is running, it makes the B cell talk to other B cells, or another cell talk to another cell. That's what that BTK does. So a BTK inhibitor blocks that. So what? BTK inhibitors are really, really exciting because they bring 2 things to the table that we've never seen before in MS ever, right? Remember I was talking about here how I said the drugs either work over here or they work over here? BTK inhibitors work both in the periphery and in the central compartment. So we've never really seen that before. Remember how I told you that some cells work on the B cells and the T cells? Do you know that that's only half of the immune system? The B cells and the T cells represent the adaptive immune system. That's half. There's another half of the immune system that you've never heard me talk about for a good reason, because I've never been able to touch it. We can't get to it until now. These BTK inhibitors, they affect B cells, and I'll tell you about that in a second, and they affect the innate immune system. We've never seen that ever before. There are cells that live in the brain, innate immune cells called microglia, and they're not very nice in the setting of MS. When the milieu in the brain is inflamed, they get really pissed off, and when they're chronically upset, they eat things they're not supposed to. So it reminds me of like the Incredible Hulk, like kind of and then eat stuff they're not supposed to, and they can cause very severe damage behind an intact blood-brain barrier. There's a term in MS called smoldering multiple sclerosis, and we think that microglia and their activation are related to that. This BTK stuff turns off activated microglia. That's really cool. We've never been able to do that before. Now, before I move on, the B cell signaling is really interesting. Remember how I was bragging about the B cell depleters, how they go and they kill the friends? That creates a risk of infection, which during a global viral pandemic is tough. But these BTK inhibitors, they don't kill B cells, they just plug their ears so they can't hear. When you break the BTK in that cell, it just can't communicate with its friends. So it's like plugging its ears, la la la, I can't hear you, and it doesn't increase the risk of infection. So there are a bunch of drugs that we're developing in MS, and we're currently studying BTK inhibitors at my center extensively, and I'm really, really excited about it. And so I was excited to share that with you. And if we could please give Bill a round of applause for not freaking out that I stole his bag.
With my wallet in.
Yeah, with his wallet, but I gave it back. It's all recorded. All right, so bind, torture, no. Drugs, sex, and salmon rolls. All right, so why are we talking about sex? Well, I love talking about sex. I really enjoy sex. And I thought that it would be appropriate for two reasons. Reason number one, well, three reasons. It's relevant to life. Number two, you just learn from a master. I mean, quite literally a master. Like, I don't know if you caught what she said. She teaches pelvic floor physical therapists. She's the professor. Like, so we learn from a master, and she's talking about the down theres. So I want to talk about the down theres. And the third reason is, in the spirit of talking about symptoms, I'm going to use sexual dysfunction as an example, and I want you to see the interweavings of how we manage sexual dysfunction. Because oftentimes, improving the quality of life with someone with MS is a little bit like unraveling twine, where you just pull on one part and then another part gets tight, you got to pull on that part, and you have to unravel it all. And so let's talk about improving sexual function in MS. Now, I'm going to try to let's do 15 different ways that we can improve sex. Number one, cardiovascular risk factors. If you have high blood pressure, uncontrolled diabetes, if you're morbidly obese, if you use tobacco, you will make the bedroom not as successful, the facts, right? And so if you reduce the tobacco use, or you control the diabetes, or you control the blood pressure, you may find that your erection improves, that you have adequate vaginal lubrication, et cetera, et cetera. It actually does make a really big difference. Now, there's lots of really good medical reasons why you should not have high blood pressure and stuff, because you'll die and things like that, but we're focused on the bedroom right now. And if you can improve cardiovascular risk factors, it'll actually improve performance in the bedroom. So just one more reason to take your blood pressure pill. Number two, we'll talk about drugs and alcohol, right? Cigarettes and whiskey and wild, wild women. There's like a trio in some people's minds. So drugs and alcohol, I'm not standing up here telling you you should never ever imbibe. I am telling you that alcohol is a sedative hypnotic. I am telling you that it can interfere with your ability to enjoy the bedroom, and so you just want to be aware of that, right? And so that might factor into how nice of an evening you have. I already mentioned that tobacco can mess with sexual function. And so I just want to sensitize you that if you're involved in those activities, which can be really fun, and you're having trouble in the bedroom, you might want to think about that or come talk to me about it. That's number two. Number three, I made a cheat sheet, I think. Oh, yeah. Sex. Get in shape. All right. Number three is to get in shape. So in the setting of multiple sclerosis, we can't live our best lives if we're not involved in exercise as part of our lifestyle. That's a true fact. And the kind of exercise that we want to consider is 4. We want balance, core strength, flexibility, and cardiovascular endurance. Well, guess what? Those all serve you very well in the bedroom. All right, and so if you're not very flexible, how are you going to get into like the reverse cowgirl? Right? Like it's hard to do that. So you may need to stretch out a little bit and practice. If your balance is off, that limits your options for positions. She's picking up what I'm putting down. She's taking notes. She's like, all right, so if you're not strong, I mean, there's a song I could quote by Ice Cube, but if you're not strong in your core and your back, it's gonna play out challenging ways in the bedroom. And so when I send you to physical therapy, it's not just so you can walk better, it's so you can do a lot of things better, right? And if that doesn't motivate you to exercise, we should talk. Number 4, medication side effects. You heard Karina talk about this. Doctors are really good at giving pills. Here, try this one. Oh, you don't like that color? Try this one. Just take them together. We'll see what happens. What we don't do a good job of is taking away pills. We're not very good at taking away pills. So I think every time you see your doctor, and for most of you that might be someone who's on stage right now, you should say, hey, do I really need all of these medicines? Is there any on this list that I can get rid of? Or is there any on this list we can cut in half? Tell me why I'm still on that one. I've been on that one for like 4 years. Are you sure I still need to be on that one? And you should challenge. And if I want to give you a medicine, say, no problem, Dr. B, which one are you going to remove? That's a fair exchange program. Now, we're talking about sex, and unfortunately, certain medications can interfere with sexual function. And so I don't think that's very nice. And the worst is some of them are really, really good antidepressants. So if you're sad, blue, and depressed, and I give you a medicine to help you with being sad, blue, and depressed, and then you can't enjoy sex, then you get sad, blue, and depressed. And right? Oh, seriously. So the important point is we need to know the side effects of the medicines, including sexual side effects, and we can make switches and changes. I'll give you an example. SSRI antidepressants are very, very popular. That's like Prozac and things like Zoloft and stuff like that. And then there's newer medicines, the SNRI medicines. It's like Celexa and Lexapro. These are great medicines, except for in the bedroom. And sometimes they can create problems in the bedroom. Now, if you understand your lotions and potions, every once in a while that'll help you. Because, for example, with Zoloft, it can cause delayed ejaculation, which is really great for someone that has a problem with premature ejaculation. Right? But most of the time, it's an issue where it dampens sex. And so I may take someone who's not performing well in the bedroom on Zoloft and switch them to a drug like Wellbutrin just to remove the sexual side effects. So lotions and potions are works in progress. And it's fair to say, what are the side effects? Any side effects in the bedroom? That's a fair question. I would love it if you asked that question. Number 5, constipation. Most people with MS are constipated. That's a fact. Most people with MS have slow gut transit. And if you're full of stool, that can cause pain. Like actually hurt. It pushes on nerves and it's all kind of other stuff. It also can make the bedroom not very fun. And so if you have trouble moving your bowels, we should work on that. Anyone that finished their internship has a black belt and I can make you poop. And even someone who has very, very serious constipation, we can do things to help you move your bowels. And you want to be evacuated before you enter the bedroom, if you can help it. And so if that's a problem, that's something that we can game out ahead of time. Make sense? Similarly, bladder. If you would like to make a human really, really upset, make them have to pee during sex. And if you want to make them really, really, really upset, make them pee during sex. And that can happen. All right? And so we want to do some things ahead of time to work on bladder beforehand. For example, sometimes my patients have honeymoon urethritis. They have sex and then they get a UTI, which is stinky. So I give them an antibiotic to take after sex. And some of them tell me they have sex every day. And I'm jealous and I give them an antibiotic every day. We can use the bladder medicines that Karina talked about, like Myrbetriq and Detrol and a bunch of others, to relax the size of the bladder so you can hold a normal amount of urine so you're not running to the bathroom halfway through foreplay. Yeah, I said foreplay. There's also medicines that can relax the bladder neck if you can't get the urine out. Sometimes you can't. You go to pee and nothing happens, and you push, you stand up, you got to sit back down. And so the point here is you don't have to let that be the case. There are things that we can do about that to make that better. One of the very best things that you can do is to avoid pre and post intercourse. You avoid pre-intercourse just to try to empty the bladder so that when there's motion and pushing and whatnot, you don't have an accident. And then afterwards, so you can empty your bladder, so any bacteria that are trying to crawl up your urethra, you send into the toilet. Right? So bladder is a very, very important thing to think about when we're trying to have meaningful intercourse. Number 7, how many is he going to do? He's really going to do 16. Number 7 is spasticity. 70% of people with MS experience spasms, cramps, Charlie horses, limbs that are hard to bend. And y'all are in Ohio, which means we get it really, really good during the winter, guys. It gets cold, and we wake up super stiff. And it's super not fun to have an extensor spasm during intercourse. That will end the session. Right? That's not sexy. Hurts really, really bad. And unfortunately, that's not uncommon. And so there are things that we can do to help that. I recommend foreplay to involve yoga. Like get naked, get on the floor, stretch, do your groove thing, watch a yoga DVD, stretch your body out, get yourself ready so you don't have spasms. If you stretch for 15 minutes before sex, you're way less likely to have spasms, which is a really great idea. There are medicines that we can use for spasms. And so sometimes before someone goes to a physical therapist, they'll take an extra baclofen. It's kind of like physical therapy, right? And so you could take an extra baclofen before intercourse to do the exact same thing. There's a bunch of things along those lines that we can do. Karina talked about spasms of the pelvic floor, which hurts like the dickens. We can use a vaginal or rectal suppository of Valium to prevent that from happening. My point is, you don't have to just say, well, that's too bad. I just can't do that anymore. Nuh-uh. Come talk to me. All right, we're on the second list, neuropathic pain. When I went to med school, University of Cincinnati last year, they told me 3 things that were false about MS. Number 1, that MS only affects the white matter. That's false. That MS only affects T cells. That's false. And they told me MS doesn't cause pain, which I thought was not true because I saw my uncle in pain, and I stood up in a class of 180, and I said, sir, I think MS causes pain. He said, no, it doesn't. Sit down. Well, he's no longer practicing, and I am. So MS does cause pain. It actually causes a lot of pain, and it can cause tricky pain. It can cause something called allodynia, doctor word, allodynia, good Scrabble word. It means that light touch doesn't feel light, it hurts. And your partner might not know that. There's another doctor term that I don't like very much called dyspareunia. That means that sexual sensation hurts. All too common. The very best way to grapple with that, call Karina, for real. Pelvic floor physical therapy is awesome at addressing that. There's a bunch of things that we can do to help with painful intercourse. I got lotions and potions you can rub on various places to numb them up or make them not hurt. There are pills and all kinds of things we can do. I would submit to you how important is it? And we can try to figure that out. But I don't want neuropathic pain to stymie your ability to get it on. Energy conservation. I want to talk about energy conservation in 2 ways. Energy conservation is super important in MS. Because if you don't plan, you may use up all your spoons of energy halfway through the day, and now you got a problem, right? Because you have the second half of the day you still have to get through. And energy conservation with any activity is very important. And I'm a big fan of this particular activity we're talking about right now, or at least I'm talking and you're being polite and listening. And so we want to think about energy conservation in really 3 ways. Way number 1 is timing of day. Many of us might consider intercourse for the first time around 9:30 p.m. because it's the very first time that the kids aren't screaming or running around like crazy people, and it's the first time you see your spouse. You're like, oh, we're married. Oh, yeah. The problem is sometimes that's a really, really bad time to have sex for someone with MS because they are absolutely exhausted. In fact, they haven't had energy since 5 p.m. and they're just trying to get through the day so they can fall asleep. And so they may not be successful. That person may find they have the most energy right when they wake up. So you may need to have a conversation with your partner. You say, guess what's happening tomorrow at 6:30 in the morning? I'm setting my alarm clock for 6 because I'm going to stretch until 6:30 and then it's on. Right? And you may have to change the timing of intercourse to coincide with when you have the most energy. You may say, I would love to have sex with you. I'll see you in an hour because I'm going to take a nap and then I'll be ready. I'm being serious. So you can recharge your battery. Another thing that we have to think about is positions. So the flying Linda is fun, and if you don't have a trapeze, then you can, but my point is certain positions use up a lot more energy than others. All right, and you may have always had sex in the same 3 positions because you never think about it, and those may be really challenging on your body. They may make you burn a lot of energy or spasm or cramp or go numb or something, and that's why the Kama Sutra is like this thick, full of all kinds of different options. And so I think that we have to be a little bit open-minded about that. I'm going to come back to that point. The third area of energy conservation that I think is so important has to do with heat sensitivity. Because sometimes when you're exercising, your body heats up. And sometimes when you're having sex, your body heats up, and it can cause things to short circuit. And I'll tell you a story about a family that I'm very fond of. And the patient is a gentleman my age. He's in a wheelchair. He's got pretty bad MS. And we gave him Ampera, which is a symptomatic pill to help with heat sensitivity. It's intended for walking speed, and he can't walk. But he has really bad truncal ataxia, and when he gets overheated, his body slumps. And if he takes Ampera, we pull it straight. So I wanted to try it. So we gave him Ampera, and I saw him back a couple months later, and I forgot to ask him about it, and he forgot to bring it up. And at the very end of the visit, I've got my hand on the door, and his wife says, "Oh, yeah, by the way, Dr. B, we forgot to talk about the Ampera." So I turned around and said, "What do you think?" She goes, "You may never take away his Ampera." I said, "Okay." And she goes, "I don't think you heard me. You may never take away his Ampera." I said, "Okay, well, spill the beans." She said, they've been together since they were kids. And at 18, when he was diagnosed with MS, he developed erectile dysfunction. And they had to do some heroic things to have a child, right? Because they couldn't have intercourse normally. She said with Ampera, he's 18 years old, which is pretty exciting. And he just sat there grinning like a goofball. And he has never stopped his Ampera. And he's in a wheelchair. And he loves his Ampera very much. And I think that's awesome. And I have asked millions and millions of people. Nobody's ever told me that except that family. But I keep trying. My point is, we might need to use a cooling vest when we're outside in August, and we might need to use a cooling vest in the bedroom depending on how vigorous our activities are, all right? But energy conservation includes heat sensitivity. Oh, good. Assist devices. Yeah. So if you have a foot drop, we have an assist device for that called an ankle foot orthosis that cocks your foot up. And if you're unsteady when you're walking because you could fall, then you can have a walker which surrounds you, and that way you're stable. Right? You can have a seat on it so you can sit down if you need it. All right, if it's hard for you to bend over, you have one of those little grabbers, reach over and grab it and then pull that thing to you. Those are assist devices. So the bedroom has assist devices, and they're more fun. So a very common assist device is a water-based lubricant. Right? So water-based lubricant increases skin sensitivity. Water-based, so it's easy to clean up. Right? And then it doesn't mess up your sex toys, which is important. A second thing that I'm a big fan of is a plug-in-the-wall vibrator. So we heard that question earlier about the vibrator. I'm a big fan, all right? And I particularly like the plug-in-the-wall vibrator. So the Hitachi Magic Wand, which is an outstanding Japanese tool for massage, shows up in every Pornhub video on the earth because it's a very effective tool. All right, and it's got to have plug-in-the-wall power. All right, and here's why. No, here's why. When you stimulate the down there's, you know the down there's. When you stimulate the down there's, the message has to go up the superhighway, all the way up the superhighway to the brain, and your brain's like, oh, okay, I can do that, and then it sends a message all the way down, back down to the down there's, so that you can have adequate arousal, lubrication, orgasm, or erection orgasm, whatever the case may be. If you have spinal cord damage from MS, sometimes the down there's get stimulated, and the message is going up the spinal cord, and it dies. And the brain never learns what's supposed to happen. So it never sends a message back down for lubrication or erection or whatever, and that's called primary sexual dysfunction. The vibrator fixes that. Allow me to explain. Right now, I'm using Aaron's indoor voice, more or less. I'm mic'd. All right, but I'm not screaming because there's not very much interference between your ear and my mouth. So I don't need to yell. But if all of you started to have personal private conversations at the same time, it would get loud in here. And if I was trying to talk to Bill, I would have to scream at the top of my lungs because there'd be so much interference between his ear and my mouth that I would have to use overdrive stimulation. That's what we can do with a vibrator. So it can't be a double D battery thing. No, you got to plug in the wall. And then you want to use a water-based lubricant because it increases skin sensitivity. And then you put that where it feels good. All right? You put that, and I'm not talking about just ladies. I'm talking about gentlemen as well, on the shaft of the penis, the head of the penis. Welcome back in the room. On the scrotum. There's a lot of different places, and it's only like $40, $50. So it's a really, and you can use it before intercourse. You can use it during intercourse between the two of you. Pretty awesome stuff. And my joke is, if you don't like it, just package it up and give it to your spouse. Say, hey, I got you something. You want to ask a question?
What about weed?
About weed? So I think it's outside the context of a assist device, but Marijuana, like alcohol, is a social lubricant of sorts, and sometimes that helps some people out, but that's kind of outside of this discussion, so we can have that conversation next time. The other assist device that I want to talk about, do I have to go hurry?
No.
I haven't even gotten to salmon rolls yet. No, we're okay. So the other assist device that I want to talk about is a sex swing. How many other people own them besides just me? Just me? You guys are missing out. So a sex swing is phenomenal because it saves energy. It's exactly what it sounds like. It's a swing, except it's not out in your backyard, it's in your bedroom. And it allows you, particularly if you have motoric difficulties, to do things that you never thought imaginable, right? Because you're floating in space. And so that's another, and it's a very inexpensive toy. I mean, assist device, all right? So those are some things that you could purchase on Amazon while you're sitting at the table. All right, so number 12 is managing depression. People impacted by MS are twice as likely to experience depression compared to the general population. That's a fact. And depression does not show up like on TV. You know, like the after-school special where you go in your room and close all the blinds and listen to The Cure and write sad poems? That's not how real humans get depressed. Men, for example, we just get shitty, we get irritable, right? And we're not very nice, we're really snappy. And one of the hallmarks of depression is a naughty word called anhedonia. Anhedonia means you don't like stuff that you used to like reading a book, watching TV, having an orgasm. And that's a bummer. And so if we treat depression with an antidepressant that's not going to impair sexual function, we can actually improve the bedroom significantly. Now, before you think that's just silly, if you would like to improve the quality of someone's life, allow them to have meaningful intercourse and watch what happens to their quality of life. Skyrockets. Why would we not want to do that? We would want to do that. Okay, coming towards the tail end of how to have better sex. We're going to start to get into some medical stuff. Men with MS, if they have low testosterone, not only do they have sexual dysfunction, but they also can have cognitive impairment and their disease gets worse faster. That's true. And so I've started to check most of the gentlemen that I take care of, their testosterone level once or twice a year. And if it's low, we can supplement that. And so testosterone replacement therapy, which has to be done under medical supervision, can be very helpful, not just for the bedroom. But it definitely helps in the bedroom, no question about it. And so testosterone therapy for men is very important. You say, well, what about us ladies? You heard earlier when Karina was talking that estrogen and progesterone are the secondary sex hormones in women, and they can be jacked up, particularly during menopause. And so we get you to the OB-GYN, and they can help us out. Or we get you to the endocrinologist, and they can help us out. Now, there are medicines that you can take to improve the bedroom. And maybe this is when I should include cannabis. But the ones that I was thinking about, I was going to divide into men and women. So men have several things at their disposal that they can use to help them with obtaining and maintaining an erection and ejaculating, right? So one thing that a gentleman can do is he can take a little blue pill, all right, Viagra. Or he could take Cialis, or there's a bunch of them now. In fact, there's even a daily Cialis if you want to be spontaneous. And so that's pretty awesome. And those don't work for all gentlemen. And for those that don't, the old school way is actually more effective. And that's a shot in the side of the whoo-hoo, and that will provide a very substantial erection. And then I'll just say to you, well, how much do you care? A vacuum pump can be very helpful. Not just like Austin Powers, but like a vacuum pump can help with maintaining an erection. And if those things don't work, a urologist can implant a prosthesis. Right, and then that can be very helpful. And so there's a lot of things that gentlemen have access to which can really help them in the bedroom. And that's why I say to you, well, how much do you care? Because if you care a whole lot, I can send you to a urologist and he can give you the XR34000. Women also have many medicines that can help them with the bedroom. Right? So we talked about a water-based lubricant. We can also use topical estrogen. So estrogen rubbed on the down theres can help with engorging blood flow and lubrication, a bunch of other things, without systemic estrogen exposure. So that can be really helpful. Show of hands if you ever heard of Scream Cream. Scream Cream is cool stuff. It is exactly what it sounds like. We have it compounded at Crosby's Pharmacy here in town, and they put a bunch of stuff in it that increases skin sensitivity and brings in blood flow. And it's pretty cool. And it's a compounded drug that I love having made. There's actually a pill for female libido, right? There's a drug called ADDY, A-D-D-Y-I. It's an interesting story. This drug was being developed by a pharmaceutical company in Columbus, a long time ago for depression. And they did a big clinical trial and it failed. The drug did not help with depression. But there was an unusual side effect that the women became sexually aroused. And they were like, wait a second, all these women are reporting that they're sexually aroused. And so they took the same drug and they did a trial looking at that and they proved that it works. And so there's an FDA-approved therapy called Addy that you can take. And I would submit that about half of our patients that take it find that it helps a bunch, and about half kind of don't. And I think that's really kind of neat that that's available. I think we're close to the end of my list. So I'm not done yet. I'm still talking about it. So pelvic floor PT, I'm just going to say that you would be very foolish if you have bowel, bladder, and bedroom problems not to talk about pelvic floor PT, because she can change your life. And she gets up in your business and teaches you how to activate the pelvic floor in ways that you didn't think possible and makes Kegels look completely stupid. My last comment on sex before we talk about salmon rolls is the most important topic. It's the most important tip. If you listen to nothing else, I'm okay with that as long as you remember this one. It's talking to your partner. Sex is by definition intimate. That's a pretty intimate activity, right? And intimate relationships and intimate activities require communication. If you're getting on a boat with a guy and you're terrified of water and can't swim, I think you should inform him of that as you get on the boat. That's a fair thing for you to do because you guys are doing something intimate. You're on a little tiny boat together and you're scared to death of water and don't know how to swim. So I think you should talk about that before you get in the water. Right? You might take some precautions, do some stretching, put on a life jacket. And so in a similar fashion, sex is something that's intimate, but it's also culturally taboo at times to talk about it, even amongst some spouses. And that can be a double problem in MS. Remember I was talking about dyspareunia, where sex hurts? That's an invisible symptom. Your spouse does not know that's happening. Your partner doesn't know that's happening. And if you're too embarrassed to tell them, how on earth can they know to change what they're doing? For real. Right? If the flying Luinda is your partner's favorite position, but your butt goes into a spasm and it hurts like the dickens, and they don't know that, they don't know that. And so talking to your partner is really, really important. It's probably the number one way of improving the bedroom. Thomas is going to lose it. So we've talked about drugs and sex, and now we're going to wrap up the lecture talking about salmon rolls. All right? Now remember that list of stuff that he wanted me to talk about? So part of that was nutrition, and part of that was wellness, and so I'm going to use that to talk about salmon rolls and talk about diet and nutrition in multiple sclerosis. Diet matters in MS a lot. And increasingly over the past couple years, I've become very, very interested in working with people to optimize their diets to help their MS symptoms. First statement, I am not aware of a diet that has been proven to slow multiple sclerosis. Allow me to repeat. I am not aware of a diet that has been proven to slow the disease process. The reason I bring that up to you is if you go to Borders bookstore or the online equivalent and say, oh, I have MS, they're going to say, oh, come here. And then they're going to show you all these books about MS and diet and this one and that one. And some of them make claims that are not scientifically supported, right? But diet can have a massive, massive impact on your quality of life. And I have seen some people do some miraculous things just by diet alone. A young lady that I take care of became half the person she used to be. She was 250 pounds. She got down to like 120 pounds. And she cut out sugar, and she cut out processed foods and fast foods and soda pop, and she dropped 3 of her medicines. Her fog's gone, her depression's gone. She walks better, she hasn't fallen in a long time. I'm very, very proud of her. That's not my medicine, that's her behavior. So let's spend a few minutes and talk about diet and nutrition as it relates to MS. Salmon roll. All right, so if we're going to think about diet and nutrition, we're going to start by playing the water game. And I'm not allowed to get off the stage, but too bad. Haha, everyone get your water ready. Any of you that follow me on social media and my live streams know what we're about to do. It's called the MS Water Challenge. When I drink, you drink. Ready? MS Water Challenge. That's good stuff. Thank you, guys. And so drinking water is underrated. Most of us are dehydrated. And in MS, that can cause a whole heck of a lot of problems. And so the goal is to drink 5 large glasses of water a day. This is not a large glass. This is a small glass. I want you to drink a glass of water with breakfast. Don't tell me you can't do that. You can. I want you to drink another glass of water at lunch. Same thing. You can do that. I know you can. I want you to drink a glass of water with dinner. I don't think that's asking too much of you. It's simply adding a glass of water with 3 meals. Now, if you want to have a beer with it, that's your business. You want to have a coffee with it, that's your business. I'm just asking you to add a glass of water to each of those meals. Then, I simply want you to drink 1 glass of water between breakfast and lunch, please. You got 4, 5, 6 hours. I'm not asking very much. Just drink 1 glass of water between breakfast and lunch. And then drink 1 glass of water between lunch and dinner. We're set. We're good. You did it. You upped your water game. And what you will find when you up your water game is you have better control of your bladder, the opposite of what most people think. Your constipation improves. Your spasticity improves. Your mood improves. Your energy levels improve. And if you don't believe me, try it. And then you can call me and apologize. Be like, I can't believe it's true. It is true, and I've seen it many, many, many times. It's really awesome. Number 1 is to up your water game. One more time, MS Water Challenge. Prost, Zumbol. All right. Next thing we're going to think about when we're talking about diet in MS is supplementing vitamin D. Vitamin D we normally get from a reaction when the sun hits our skin. It changes something and creates vitamin D. So if you go out shirtless or close to shirtless in the full sun for 15 minutes, your neighbors will be very confused and you will absorb 5,000 international units of D3, right? Which is pretty much what most people need to take as supplementation. But the problem is, for 7 months in Ohio, you would get frostbite, and it would be uncomfortable, and so you can't really go out half naked for 50 minutes in the sun. So instead, you take a little D3 pill, all right? You pick it up over the counter. I like D3 instead of 2 because I think D3 is better absorbed in the human body. And the goal is not just to take a bunch of D3, it's to drive the level above 50 but below 100. The data is pretty darn clear that if you have a low vitamin D pre-puberty, you increase your risk to get MS. And if you have MS and you have a low vitamin D, you make your disease get worse faster. And if you slow it down, it looks like, if you increase your vitamin D, it looks like that slows the disease down. And so I want you to get some vitamin D, right? Now, if you wanted to do vitamin D more naturally, there are some things like beef liver and stuff that you can eat, cod oil and stuff like that. I'm just taking a D3 pill personally. So after we've done the water game and the vitamin D, there's 2 more supplements that I want to get into. One of them is probiotics. Show of hands, people familiar with probiotics? Probiotics is a game changer. And I'm at the point now where I'm almost not requiring, but I'm asking all of my patients to take probiotics. It turns out that in the setting of MS, the bacteria that are in your gut, the gut flora, are goofy. They're the wrong gut flora. We don't know why exactly, but they're not the right kinds. And that's called dysbiosis. And that's part of the reason why so many people have IBS or constipation with MS. Probiotic is a capsule with billions of healthy bacteria, and it repopulates your gut. You can do that by eating kefir or by eating natural yogurt or sauerkraut or anything like that. But I really think that it's helpful for gut health big time. It's helpful for bloating, it's helpful for getting you to move your bowels, and if you have constipation, it kind of pulls you in the center, and if you have diarrhea, it seems to pull you in the center. And so I'm a big fan. Which kind? Don't know. We don't know what's the best kind. So there's a question about the immune system and where it's located, and is there an immune system in your stomach? And there is an immune system in your stomach. It's called MALT. And so when you eat something, your stomach your gut is going to come in contact with foreign stuff, and so you have an immune surveillance of your gut in case what you're eating is bad for you, in case there's bacteria in your gut. Now, it's actually very, very complicated because we wonder whether or not if we change the gut flora, we can change MS. And that's a works in progress. So when I tell you to take probiotics, it's not for that purpose. It's for gut health. But that's a very interesting story that's ever evolving. In addition to probiotics, I think we need to take fiber. Fiber is an indigestible solid like sawdust. So if you're a woodworker, you don't need to buy anything. And when you eat sawdust, it goes in here, it comes out there. All right? And if you eat sawdust with nothing else, you're going to create cement, which is not a good idea. But remember the water game? When you add sawdust and water and mix it together, it swells like a sponge. That mixes with the stool. It makes it big and bulky, easy to hold on to, easy to pass, lovely. And so adding in some fiber is the jam. 2 more recommendations as it relates to MS and nutrition. And they're really hard to do, super hard to do. The next recommendation is to only eat things that have single ingredients. Like the ingredient is asparagus, chicken, apple, broccoli, dog. It's just one ingredient. I'm joking about the dog. And so I want you to eat real foods and whole foods. So I want you to avoid processed foods. I want you to avoid foods that are fried. I want you to avoid fast food. I want you to avoid soda. I want you to avoid diet beverages. This is very hard to do. It's very hard to do. All right? It changes the way that you shop at the grocery store because you can't shop in the center of the grocery store. Food should rot. Right? So if you have something in the freezer, it'll stay there for years and years. You can put it in the cupboard, it stays there for years and years. If you want to do something very scary on your way home, buy a McDonald's cheeseburger, unwrap it, set it on your dining room table, and leave it there for 10 years. It won't change. No, I'm being dead serious. You look at it a couple years later, it looks just like a hamburger. That's not food, that's a chemical. Also, if you're reading the ingredients of something and you can't pronounce it without a PhD, that's not food, that's a chemical. And so if you really want to clean up your diet, you don't have to ascribe to Dr. So-and-so or Hoodsy What's-Its. I just want you to eat real food, whole food, and single ingredient foods. And it's life-changing. And if you don't believe me, try it for a month, and then you can apologize. I mean, then you can tell me what your experience was. Now, the last thing I want to talk about before we wrap up today is about intermittent fasting. And some of you might be sick and tired of me babbling about intermittent fasting because I've become so excited about it. Show of hands if you've heard of intermittent fasting. Thank you, guys. So intermittent fasting is a biohack that helped me lose 40 pounds and keep it off. So during the pandemic, I sat in front of an iPad and didn't move and ate all day long. I was good at it, right? I wake up in the morning, I wake up like 5:30 in the morning, coffee with cream and sugar, spiking my insulin. Then I get to work. I'm not going to eat at work. Not going to eat at work until I see a Danish. I'm not eating. I'm not eating. All right? And then I'm going along, there's a muffin, but I'm not eating breakfast. I'm busy in clinic. And then there's lunch. So I eat that. That was good. And then I take some home because there's a bunch left over, and I eat that. And then I eat dinner. And then after dinner, I need to have a snack when the kids have a snack. And then it is my house. I own the house. I pay for it. It's my refrigerator. Yes, it's midnight. No, I'm not going to not eat that. And I'm sitting there eating cottage cheese out of the can with, right? And here's what happens. When you eat a food, it spikes your insulin. Insulin is the storage hormone. When insulin levels are high, you can't burn fat. That's a signal to store anything you put in your body. So if I have my coffee with cream and sugar in it, I spike my insulin, and then I eat a Danish, two options. If I am running, I can use the Danish for fuel. I wasn't running. If I'm sitting, I can store it for later. And I did, although a lot of it was here. And the problem is that I never let my insulin levels fall back down. For real. Like I was eating all day long. I was eating like 6 meals a day, which is the average number of meals that Americans eat. And I was gaining a lot of weight. And I have all these custom-made suits, and I couldn't fit into them, which is very embarrassing. So either A, I needed a second job to buy all new suits, or I needed to lose some weight right now. And so I did what I was taught in med school. Exercise more, eat less. Didn't work, which is frustrating because I've been telling people to do that for 2 decades. And so then I did a Google search for how do doctors lose weight, for real. And the answer was intermittent fasting. And so I read a book on intermittent fasting, and then I got really excited about intermittent fasting, and then I did intermittent fasting, and then I studied it in the setting of MS, and guess what? It's safe in MS. And now I've been talking about it to patients, and guess what? A lot of my patients are losing weight, and they're keeping it off, and it makes me feel really good. And I want to tell you, before I tell you about intermittent fasting, I want to tell you about a young man in his early 30s, and he's very affected by his MS. He can't move his legs, and he can move one arm kinda. The other one he can't move very well. So he's in a wheelchair. And as you imagine, he had gained a lot of weight. Not his fault, he couldn't move. He came in to see me and he had lost about as much weight as I had. He looked gorgeous, he was doing fantastic, he looked really thin. He had a smile from ear to ear. His wife is smiling from ear to ear. I said, what happened? He goes, I watched your video on intermittent fasting and I've been doing it and it works. And it changed his life because his decubitus ulcers are healing and he has more positions and his physical therapist can do more than they've ever done before. And so real quick, here's the dealio. I eat from noon until 8 p.m. That's 8 hours. And then from 8 p.m. until noon, I don't eat. That's 16 hours. So during 8 hours, I take on nutrition and energy. And once I take on the energy, then I give myself time to burn the energy. So real quick, not to be nerdy, When you stop eating for the first 6 hours, your body uses the sugar that you've given it, stored in your liver, and it burns through that store. At about 6 to 8 hours, you don't have any more sugar in your body, and if there was no other food source, you would just die, which doesn't happen while you're sleeping, because your body then flips into burning fat, lipolysis. And as soon as you eat, that stops. So by not eating breakfast and not eating until lunch, I'm burning fat through my sleep, and I'm burning fat through the morning, and I'm burning fat until I break my fast at noon, which I did right before this lecture. And then I'll stop eating at 8 p.m. Now there's a lot more to it, but I'm going to run out of time. And I want to review that today's goal was to figure out how to live your best life despite having MS through the means of drugs, sex, and salmon rolls. Thank you.
Awesome. Thank you. Yes. And so I asked him to do all this about a half hour before he arrived. Isn't that great? He put it all together? Awesome. Thank you. All right. For anybody who's got questions, again, please raise your hand. Let me see who you are. I do have a lot of questions that came in online, a lot of them sexually related, which the doctor will like. All right. And yeah, very, very sexually related. I'm not going to say the people's names because they are so sexually related. All right. So if anybody does have a question in the audience, please just show who you are. There is a young lady in the back of the room, of course, because she has questions everywhere we go. So I will go back there first. All right. I'm getting back there, all right? I'm off camera. It's okay. I'm off camera. Sorry.
Can you talk about prebiotics and probiotics?
No, because I don't know about them. So I actually don't, I can't speak to that. You got me. You stumped me. Guess what I'm going to read about tonight?
Stumped. Men with or limited to no sensation in the down theres. Mm-hmm. Okay, zero sensation. What is it that's available for them to gain the sensation to have sexual arousal?
That's going to involve the assistance of a urologist. Not a new urologist, but a urologist. And we're going to have to get into some fancy discussions of which nerves are involved. And we might have to be creative, because when you say the down there's, you can't feel it, I want them everywhere? Under the left testicle? I mean, is it nowhere? And so we may have to work with a urologist, and we may have to work with a pelvic floor physical therapist. We also may have to look at some of the medicines that we're using and tweak some of them. And I'm not promising we can make that better, but I think that we should definitely try.
Okay, great. Thank you. Somebody says they don't have any questions because you were such a fabulous speaker. There are no questions to be asked. Okay.
Lies and flattery will get you everywhere.
Exactly. Exactly. Another person wants to know, can you please repeat the intermittent fasting times?
So I have a YouTube channel, and I have a lot of YouTube videos on intermittent fasting. The kind of intermittent fasting that I do, that I recommend to my patients, is called 16-8, where you eat for 8 hours and then you fast for 16. Basically, I eat 2 meals a day.
Another person writes, thank you for not trying to answer something you know nothing about.
Yeah, I am very happy to not make stuff up.
Okay, great. Next, bladder, feeling the need to pee when sitting in a car. What can be done? Every time he or she gets into a car, the feeling is to be there even though they just went.
So that's not uncommon, right? And in fact, sometimes you can have a problem with the bladder where the bladder neck is really tight. So there's urine in the bladder, and you go to pee and you can't get it all out. And so you say, I just went, but I got to go again. And then you go and you tinkle only a little because you can't get the urine out. So there's a couple things you can do in that situation. There's actually a medicine that you can take. Both men and women can benefit from it. It was invented for men's prostates. So when I prescribe it to women, I always find that funny. But it doesn't work on the prostate. It works on the smooth muscle of the urethra. And it relaxes it. And that medicine is called Flow Max, because it does. And so we can prescribe Flow Max for some people. And that can be very helpful. If Flow Max doesn't work, there's a couple of heart medicines like Cardura that will also do the same thing and open up the bladder neck. If that doesn't work, we can use a catheter. And before you go, I don't want you can't. Once you learn how to use a catheter, it's life-changing. It's freeing. And it's a game changer. And almost without exception, my patients who have mastered catheterization are true believers. Because now they're impervious, you can carry a catheter, a woman's catheter can collapse into your palm like this, can't see it. Whip it out, use it, throw it out, move on, good stuff.
Does this mean the people aren't fully emptying?
Probably. Yeah, so at our center, we use a bladder ultrasound. So I can have you go pee-pee, and then I can see how much is left over, and that'll help me clarify if that's the problem, and I know whether or not I need to use the medicines.
Great. This next person has a question which I do not even know if I should be asking because it sounds a little kinky, very kinky. Forget that. I don't even know where it comes from. We're talking about dogs and sex here, right? Doc, question for Boster. What can work well is something, first a statement, that can be brought into the bedroom is a cooling pad. I have a Newfoundland dog. I bought him a cooling pad. He's very heat sensitive. Also, I have the same cooling pad for myself.
Nice. That's awesome.
Right?
So I think that's fantastic. So here we have someone who is identifying that heat sensitivity and motor fatigue can interfere with the bedroom. And so the way that they're cooling themselves is by having a sheet that is cooled. That's brilliant. Thank you for that tip.
Into the mic, not me. I mean to the camera right here.
Yeah, that's a really, really good idea.
Okay,
Thank you for
great.
that. I'm going to take that one home
Good.
as I Google where to buy them.
Fantastic. Here's a person asking for you to talk more about the sex swing.
So it's simply an issue of mechanics. All right. So in order to have intercourse, you have to agree on some positions, and they may not be stable. And if you already are a little off balance, you could fall over or not have a good time, or there's a bunch of. So a sex swing is just a swing, except there's an eye bolt in your bedroom ceiling as opposed to outside. And you can sit on it or lay on it, and you can position yourself on it. So imagine a situation, for example, where the partner can't move their legs very well, right? If they were in a sex swing, they could face their partner and they're just swinging, and their partner can pull them forward and push them away, and they spend no energy and they can't use their legs, and it doesn't matter. And so it's a tool that can assist with intercourse and not have to spend any energy, and it's fun.
Something really important about that bolt in the ceiling. Make sure it goes into a beam.
Yeah. You don't want to just put That was a very important comment.
Yes, sir. That would be me. Handy spam.
Bam!
All right. Next one. Wow. Really getting sensitive here. A woman wants to know, because her other half thinks that something's wrong with her, she squirts when she's having sex uncontrollably, and it's like nonstop every time he penetrates her. So she wants to know if that's bladder issues or something sexual.
So I'm going to use this to talk about losing your bladder during intercourse, which may or may not be what's happening. All right. So first of all, you should be able to, if you can't talk to your sex partner about peeing your pants, they shouldn't be your sex partner. Like you should be able to, come on, you get naked. Like you should be able to talk about that, right? And if you talk about it, you'd be amazed at how readily they don't care. Seriously. And so you say, hey, sometimes I can lose my bladder a little bit, sorry if I pee on your head or, whatever the case may be. And so having that conversation is really, really disarming. Now, I made an off-color joke on purpose because you can use humor to help bring the topic up and so that it's not so weird. And then also there's things that we can do to empty our bladder before we have intercourse. And so that catheter, you might not use it anytime except for Friday night, right? When you drain your bladder before intercourse, because then you guarantee that it's empty. And those are things that are really important.
Thank you. Next one is, person wants to know, for this spoon theory, how much time is a spoon actually, because how else does he or she determine how many spoons per day?
Show of hands if you're familiar with spoon theory. Cool. I love spoon theory. I did not make up spoon theory. Spoon theory was created by a woman with a chronic condition, lupus. And it works perfectly when discussing energy and multiple sclerosis. So real quick, spoon theory 101. Is there any spoons on the table? Did they take them all away? Oh, excuse me. Stuart, don't look.
I'm not looking. He's taking his time running around the room.
All right, I got some spoons
grabbing a
here.
whole bunch of spoons, and now we're going to learn how much time a spoon
Howdy!
is.
No. All right, so spoon theory works like this. You wake up in the morning with all the spoons you're going to have for the day. So a spoon is a unit of energy. So you wake up, I have 50 spoons, and I'm going to get ready in the morning, take my shower. I'm going to get dressed for the day. I'm going to make my son eat eggs. I'm going to clean up his dishes because he refuses. I'm going to put my dog and my son in the car and drive him to school and drop him off. Then I'm going to have to get my dog to my office inside. All right, and then I'm going to see my first patient. All right, so by 8 o'clock, I've used, a handful of spoons. And as I go throughout my day, I keep using spoons. All right, and then I go to bed and I replenish my spoons for the next day. That's spoon theory. Here's the deal. When you have multiple sclerosis, you don't wake up with 50 spoons. You wake up with 4 spoons. Good morning. Start your day. Gonna take a shower. Gonna have breakfast. Gonna get my kids to school. I'm gonna get myself to work. I don't have more spoons. That's multiple sclerosis. And that tool is very, very helpful to explain to a spouse or a coworker, I'm out of spoons right now. If you push, you dip into tomorrow's spoons. And you pay what I call the devil's price. Because the next day you start with no spoons. Now, if you're aware of that and you're trying to have sex, then you're going to save some spoons. Yes, I could go to the store, but I'm not going to go to the store. Yes, I could do the dishes. I'm not going to do the dishes. Yes, I can mow the lawn, but I am not going to mow the lawn because these I'm saving for 8:30 p.m. when my kids leave to go to the store, right? Because I'm going to save spoons. Now, the question was, what's the exact unit of measurement? There is no exact unit of measurement. It's a concept. And where I would like you to use the concept is in your home with your family. I want you to teach them about spoon theory because it's very easy to say, I don't have any spoons left. And then that means something. That's a culture of knowing. Good question. Thank you for your spoons, guys.
Great, fabulous. Any questions out in the audience before I continue with the online ones? Nope. Okay. They're all entertaining. They're liking what's going on here. All right, next one.
Fork theory. No, I'm joking.
That would be forks over knives. Okay. I'll be there in a moment, all right? I just got to get this one done, and then I'll run over there. All right. To a nutrition type thing. There's a few of those coming up. All right. The National MS Society seems to be backing a person named Terry Wahls for the Wahls Protocol. The Wahls Protocol and diet, what is there to say about that?
So there's a person in the United States named Terry, and she has MS, and she is an internal medicine doctor, and she came up with a diet for herself, and she wrote a book, and she made claims in the book that she never proved. She said that she could cure multiple sclerosis with her diet, which is not true. And then she sold her book to millions of people and made a lot of money and got famous. And that doesn't sit very well with me. Not because she came up with a diet that she likes. Not even because she made a claim that's not true. My problem is when she made that book, she wrote the title and her author, Dr. Terry Wahls, MD. I have a problem with that. Because in our culture, if you put M and D after your name, people talking to you think you know what you're talking about. Remember earlier when I was asked about prebiotics? I don't know anything about prebiotics. And I'm not going to lie to you. I don't want to make it up. I'm going to read about it tonight. Next time I'm asked that question, I'll know the answer. So the Wahls Protocol might help people with fatigue. We're currently studying it to see if it helps with fatigue. And I have patients who have used the Wahls Protocol and they feel better on it, and I think that's awesome. But I have a problem with the concept of false hope. And I'm very bothered when there's claims made and then people buy books or they stop medicines or their family gives them a hard time because they're not following the Wahls Protocol. So that's a little bit bothersome to me. Now, I don't know Dr. Wahls. I bet she's awesome. I bet she's a really smart woman. I bet that she's done a lot to contribute to the field. And I'm not trying to take away from that. I just am bothered when you're told something that isn't proven because that's not fair to you.
I'm taking a question from over here.
Well, as you just saw, my husband has really bad trigeminal headaches. There's no control. We heard possibly a hyperbaric chamber may help. Is that possible?
So, first of all, for those of you that are not familiar, trigeminal neuralgia is described as the single worst pain a human being can experience. The single worst pain that a human can experience. Trigeminal neuralgia. And it's a beast. And in the setting of MS, you're 14 times more likely to experience it than the general population. Sometimes nature's too generous. Now, sometimes trigeminal neuralgia is easy to treat. Sometimes it's really, really hard to treat. And there's a lot of different things we try to do. So the question is, what about hyperbaric oxygen? The data is not very good, but it ain't going to hurt them. And so when I'm thinking about something where there's not awesome data, when I'm not sure, I want to make sure it's not too expensive. I want to make sure it's not instead of something that we know works, which in this case is we're having trouble. And I want to make sure it's not dangerous, and that's not dangerous. So I would apply those rules to that. Like, let's pretend you had to mortgage the house to do it, not a good idea. But if it was within budget, it's not dangerous, and it's not instead of something we know works, let's do that. And if it works, let's do that a lot.
So that everybody knows, I also have problems with trigeminal neuralgia, and I almost found a freight train one time to help me get rid of it. Okay, it's really severe. Okay, and that was to be my only way to get rid of that pain that I was getting, which was just on the side of the face and just destroying me daily for 3 straight days. So,
and it's an invisible symptom.
And it is. And when he just went through what he did, it just brought back, I mean, I got tears in my eyes from what you just went through, right?
Okay. It also gives us a quick opportunity to point out that people sitting in this room are tough. You look like normal people, but you're not. Honey, you look so good. Well, you're faking well half the time. And so why don't we congratulate each other for being tough?
All right, person online is saying that she would like to know if you can discuss anything about NFL and having nothing to do with the National Football League.
That's good, because I don't know very much about the foosball. Right. Now, I'm from Columbus, Ohio, and I did my training at University of Michigan up in Ann Arbor, and they gave me a really hard time for being from Columbus. And then I came back and I was an assistant professor at Ohio State, and they gave me a hard time for training at Michigan, and at no point in time did anyone ever invite me to touch a football. But that's not what NFL is about in the world of MS neurology. So when you think about the nervous system, you think about a neuron, that's the cell of the nervous system. And the neuron has a body, and then it has a projection that comes out here where it connects to another neuron. So you can send a message down that wire, right? That wire is called an axon. If you crack the axon, all the guts inside spill out. And in that axon are these chains. There's a heavy chain, and a medium chain, and a light chain, right? And those chains spill out into the spinal fluid, and they make their way in the bloodstream. Turns out that neurofilament light chain, so that's one of those 3 chains inside the axon, the amount in the bloodstream correlates beautifully with disease activity. So the higher the neurofilament light chain, the worse the disease is. And it's getting really, really exciting, because what we found is if someone with MS isn't on a therapy and their neurofilament light chain's up here, and you put them on a mild therapy, it drops a bit. And you put them on a really effective therapy, and it normalizes. And someone who has a low neurofilament light chain, a couple months before an attack, it'll spike. And if they're progressing, it'll go up. And so it feels like we're on the verge of a new biomarker to help us understand MS. Right now, the best I can do, which is not bad, is I can ask you how you're doing, I can run you through the MS Olympics and take pictures of your head and neck, and then I can use those pieces of information to try to sort out if we're doing okay. And that's a good way to do it. I mean, that's the way we do it. But adding neurofilament light chain is a game changer properly. And what I imagine is we would check neurofilament light chain every quarter. We would check it when we start a drug. We'd check it 6 months after, and we would use it frequently. We'd probably order MRIs less often, and we would make treatment changes based on that. Now, it's not prime time yet. And there's still a lot of things that have to be sorted out. For example, as human beings get older, their neurofilament light chain goes up. So like a 60-year-old will have a higher baseline neurofilament light chain than a 20-year-old. And so we have to figure out like the baselines and all the reference arms and all that kind of stuff. And it's work that's ongoing right now. Very, very exciting. And I think it'll probably be prime time in the next couple years. If you happen to have just over $1 million, you can actually buy the machine that'll process it. I just haven't found that yet.
If it's primetime, it'd be great. It's primetime live, NFL.
There you go.
There you go. You said something really great about that McDonald's burger. There was in the news recently a person who was doing reconstruction in their home, and they found in the wall that they broke out, they found McDonald's hamburgers from 30 years prior still intact. still intact.
That's awesome. That's
right?
my point.
Bugs didn't even want them. That's the bottom line. The bugs did not want the burgers. All right. Next, we have Pamela wants to know if it's true or not that MS attacks people more or less or not at all, because are they more susceptible for COVID?
So multiple sclerosis is a condition where your immune system's overly active. It's revved up. You're not immunosuppressed. You're over-immunized. Your immune system's overly active. So you're not at increased risk of an infection. And so having MS by itself does not increase the risk of any infection, including COVID. Now, some of the medicines I give you can increase the risk of a more severe outcome, but that depends on the individual medicine, not the underlying condition.
Thank you. Next, what's your thoughts on B12 for energy and remyelination?
So B12 is something that you can get through animal products. Like, so if you're a strict vegan, it's very hard to get B12 in your diet. Unfortunately, a lot of vegans cheat enough that they can have some B12 in their diet. You can get B12 from a pill that you can take. And if you have a low B12, it can cause neurological problems, like difficulty thinking or burning in your feet and stuff like that. And oftentimes when we're working someone up for MS, we may check a B12 level because energy is an issue when you have low B12 and energy is an issue in MS. I do not recommend that people run out and take B12 just to take it. If you have a deficiency, then I want you to supplement it. Otherwise, I typically recommend you just take a multivitamin. Taking a B12 or a B complex is not going to hurt you. I just think it's not necessary most of the time.
Okay, thank you for that. Next, back to COVID stuff. Is it, I don't know how to word this, but there are a lot of people that get enhanced symptoms from COVID. Can you speak about that, please?
Yes. So COVID is not the flu. And I think a lot of humans sort of just imagine like a respiratory illness as being like the flu, even if they know with words it's not. They kind of emotionally think of it as, and it's not. And we don't understand a lot of stuff about COVID still. And when COVID attacks a human being with MS, it's more complicated than when it attacks someone without MS. Because what I've learned over the last 2 years is many people have an uptick of their MS symptoms during COVID, like they would with any other febrile illness, with an addition. When the COVID ends, the symptoms don't go away right away. And in fact, I've seen people that have an uptick of symptoms for like a month or two afterwards. It's not a new attack, it's old stuff that has just kind of kicked up. And it's really, really frustrating and very annoying. And in some people, it's actually triggered an attack. That's rare, but I've seen it. It's a very, very difficult condition. Now, full disclosure, I've also seen people when they get their COVID shot, they can have an uptick of symptoms. And so it's a very challenging thing. I guess where I fall is as follows. If you actually have COVID, you risk worse neurological symptoms for a lot longer, in my experience, than with the vaccine. Now that's a general statement. Each individual human being has to think through that and hopefully work with their clinician to figure out what's the right decision. It's a challenging thing, and this is not flu. We've lost a lot of patients in my practice. They've died. They're no longer alive. They died from COVID, and that's terrible. And so I think we have to be very, very aware of that. And I don't want you to take that information and say, well, I'm not going to get vaccinated, because getting COVID, you're going to have a bunch of neurosymptoms that you don't want.
That's right. And as I told the audience earlier, I had COVID twice, okay? And I was vaccinated and boosted when I got first time in January, all right? So it doesn't stop just because the medications either. And is it my schedule? I have no idea. Is it where I've been? I have no idea. I was the one that was most concerned about mask wearing and everything else, and washing hands and doing everything and making sure that I'm not going to get it, and I got it. And yes, it
probably by being
symptoms.
vaccinated, the course of the condition was a lot less severe than if you hadn't been vaccinated.
Right. Okay, a few questions remain. First one online is a person asking if fish, grass-fed, lean meat, chicken should do more. Which one should be better than another?
So those all sound like good sources of lean protein to me. Fish, chicken, beef, lamb. I think that some of it's kind of your own personal taste, but I think, you know, the point that I'll make with that question is you got to have enough protein in your diet. And a lot of Americans don't have enough protein in your diet. So if you take your body weight and cut it in half, that's the number of grams of protein that you need a day. close. It's a little bit less than that. So a lot of guys need to eat like over 100 grams of protein a day. And if you look at like a corned beef sandwich, there may be like 5 grams of protein in that. So it's hard to get enough protein in. You got to kind of pay attention. And so those meats that you described are great sources of healthy protein.
All right. Next, anyone out here have a question? Oh, there we go. All right, great.
Back to the proteins. Do you like the wheys?
No. So there's different kinds of protein. So when you process milk, you have a bunch of extra stuff left over. Instead of throwing it out, they put it in a jar and sell it to you. And it's a type of milk protein. It's not horrible, but no, that's not my preference.
Yes, I'm curious about, I'm supposed to get an infusion, and I'm supposed to get 2 shots on each side of my hip. Are you familiar with that?
Are you talking about Evusheld?
Is that what it's called?
Is it for COVID?
Yes.
Yes, I can talk to you about that. So we have learned a lot about how to beat up on COVID, right? And the number one thing you can do is wear a mask and wash your hands and stay out of the fray and get a vaccine. Those are the number one things that we can do to help us. If you are immunosuppressed, either because you have cancer, God forbid, or because you have MS and you're on an immunosuppressant or what have you, then you have an increased risk that if you contract the COVID, it could be more severe. And you're therefore eligible for a treatment called Evusheld. Evusheld was rapidly developed. It's still considered experimental, and it's only available for people that are immunosuppressed. So a lot of people with MS qualify because of the medicines that they're on. And it's 2 shots. They're 2 different monoclonal antibodies, which are like smart bombs. And so you jab them in you, and you have drugs floating around your body that will whoop COVID's butt if you get COVID for 6 months. So it's kind of like you hire 2 bodyguards to walk behind you, and they just walk behind you, and if someone messes with you, they smack them. And otherwise, they just walk behind you and you don't pay attention to them. And so for someone who is immunosuppressed, that's a really awesome thing to have, and I endorse that. I'm sad because I can't get it prescribed very easily. It's very hard to get a hold of. It's not commercially available, and the government controls it and delves it out as they see fit. And so if you're able to get it, I'm delighted. I just wish I could figure out where it is so I could source it to make it available to my patients.
So from the largest MS centers in the country are having that same issue. So it's not just that it's you that's without this availability. Okay, next, we have 2 questions remaining. And by the way, I want to thank everybody that's online today, because we had 86 people online today, all right? And that's freaking awesome, I'm glad to say. Thank you. All right, next person writes, what the heck is a biosimilar and its relation to a generic or a brand medication?
Yep. So the first part of my talk was on drugs. So medicines for MS come in different flavors. When you develop an MS medicine and get it approved by the FDA, then you'll have a branded medicine, and it's on label, right? And then that patent lasts for like a certain amount of time. And during that time, you're not allowed to make another drug like that. Like the manufacturer has unique rights to it, and they use that time to sell the drug so they can recoup the R&D costs that they spent, which is fair, right? So after a certain amount of time, the drug can become allowed to be made in different ways, and you can develop a generic, all right? And so there's different kinds of generics. So a biosimilar is when you have a biologic agent and you make one that looks really, really, really similar to it, and hopefully has the same properties. And any field that has drugs that have been around long enough, you're going to start to see biosimilars. So for example, we talked earlier about a drug Tecfidera. So Tecfidera is dimethylfumarate. Well, there's now 2 other Tecfidera-like products out there that are biosimilars. So glutathione acetate, Copaxone, there are biosimilars. And so that's part and parcel to what we see. Now, the issue becomes if they have the same efficacy. And the rules to study a biosimilar are not the same rigorous rules when you study a drug for the first time. You do not, for example, have to prove efficacy sometimes. You just have to prove that chemically they're very similar. So it can make doctors a little bit anxious when we're prescribing these medicines as biosimilars. Sometimes there's actually clinical trials that will support that it really does do what it says it does. So what does that mean to you? Well, it's your body and it's your brain and it's your insurance money that's paying for the drug. And so you're allowed to say, hey, is that okay? And you're allowed to ask your doctor about it. And we're allowed to write 3 letters at the bottom of a prescription, DAW, which means, nuh-uh, you have to do it the way I said. And you can't switch it on them. Dispense as written. And so you can sometimes run into a situation where someone will switch you to a biosimilar and then switch you back. Let me give you an example of a biosimilar sort of that I kind of think is cool. Right? So there's a great drug for MS called teriflunomide, Aubagio, like the drug a lot. All right, it's a pill you take once a day. It's unfortunately kind of expensive. And as long as you have insurance, that's cool. But if you don't have insurance, it's not cool because it's very, very expensive. Well, there's a rheumatoid arthritis drug called Arava. And when you swallow Arava, the first metabolite is Aubagio. And Arava costs about $20. It's generic. And so if people don't have access to insurance, then we just do that. That's off-label. But it's an example of similar medicine chemically. And so it allows us to get someone treated when they need to be treated. That was a good question.
Thank you. Which takes me to the question that was last, which you were partially answering there already, is how would the individual fight to keep and stay on the medication that they know is working for them when their insurance company is insisting that they switch to a generic?
So very common. Now, why is the insurance company doing that? Right? It's not because they're bad or evil. It's because they're trying to manage a population of humans. So I care for one individual, right? Just the person I'm dealing with. They have 1 million people, and they have to provide all the medicines for that 1 million people, right? And so MS drugs are super duper expensive. If they can put you on a generic, they can save cost, and that way more people within that network get treated. Now, that's not the way it feels to me. To me, as the doctor being told, no, you can't do the thing that you asked, that's very frustrating to me. And so there are some opportunities to try to change that. So one thing is when that happens, your doctor can write a letter and say, no, they aren't responding to that generic, or they don't handle that generic very well, or we're very concerned that it's not equivalence. And I can try to explain to the insurance company why that's not okay. And sometimes they may say, all right, fine, or sometimes they may say no. You also, the patient can write a letter. The patient can write a letter. Now, there's one person that the insurance company listens to more than anybody else. Do you know who that is? The payer. So the insurance company is hired by an employer. So you can have your employer who pays for the insurance, you can have them write a letter and say, no, the covered life that we gave you, give them that medicine. Sometimes, despite all of that, we're not able to, and we have to put someone on a medicine like a generic. And if it works, groovy. And if it doesn't work, then we can go back and say, we tried, it didn't work. And then they're more apt to be able to give it to you. How do we determine if it doesn't work? Well, that's what the patient tells me. Oh, I'm sorry. Go on.
No, it's to you. No, that was the last question, but I did want to thank you, and I want to thank a person who just wrote something online, and that is that a couple of people wrote in today that they've been following all this since about MS Views and News since it was Stu's Views and MS News, all right, which is what it was prior to MS Views and News. Thank you for noticing as well. And yeah, I've been, as I mentioned before, and I heard somebody say, oh, wow, I didn't know that. And people wrote in online when I mentioned that I'm also a person living with MS. I've listened to doctors like Dr. Boster. I've listened to people like Dr. Thrower, Dr. Legank, Dr. Mitzi Williams, Dr. A lot of them out there. You got to listen to them, and you could do so much better. I mean, the medications are there to help you, all right? But you got to use them, all right? There are a lot of people who are on orals. Say, hey, yeah, great, I have to do it twice a day. Well, maybe just one a day will work. No, it doesn't. All right, so you really got to stick with it. We want to thank all of our supporters. Of course, we can't do our programs without those that are in attendance, as well as online, as well as in person. So I do want to thank you all, and for our great speakers like Dr. Boster. We can't do these programs without you all. So thank you for coming, and you all have a great day. Bye-bye.